Hello, everyone. Welcome to the webinar. We're going to get started in a few minutes. We'll let folks join, and in maybe 2 or 3 minutes, we'll go ahead and get started. So thanks to you all for joining.
I think
All
that is
right.
time, Ben.
Yeah, I think so. All right, everybody. So that's 5 past the hour. So I think we'll go ahead and get started. We got a good number of attendees on the call. So thank you for joining us today. So we're really excited about this webinar. This is something that we've been working on for probably at least 3 to 4 years. So this was really thought of trying to bring these two organizations together for this joint webinar series through the ASPHO Global SIG and SIOP North America. And so the folks that have been involved in this from the ASPHO Global SIG part of it is Maz Ozua from Texas Children's. So he's actually based in Malawi and is traveling right now. So he's not going to be able to attend the call today, but you'll see him on future webinars. Myself, I'm based out of New Orleans. I'm at Tulane and Manning Family Children's. And then from our SIOP North America Global Health Committee, we have Jeremy Sloan from St. Jude, as well as Cesar Nunez from MD Anderson. So also want to thank both the organizations, SIOP and ASPHO, for helping support this webinar series. So we figured we would start this with just doing a few introductory slides, since this is our first one, before we get into the talk. So starting with, I think most people are familiar with ASPHO and SIOP, but we thought we would give a brief background. So ASPHO, the American Society of Pediatric Hematology Oncology, is made up of about 2,000 members. This includes physicians, APPs, med students, residents, fellows, et cetera. A large component of ASPHO is education. The mission of ASPHO is to support and empower the pediatric hematology and oncology medical and scientific community. As part of ASPHO, we have the ASPHO Global SIG, the special interest group. This is made up of actually about a quarter of the members of ASPHO. So this is a lot of good participation from ASPHO with this, with about 450 members. Our goal within the Global SIG is to foster and support active participation and collaboration in global hematology and oncology initiatives. What we found within ASPHO is that there were a lot of people that were really interested in global health, as well as a lot of people that were participating in global health, but we didn't know what each other were doing. And so a part of this global SIG work over the last couple of years is better defining what people are doing, developing a roster so we know where people are working. Sometimes we found that people are working in the same country, in the same city, and never knew it. And so a part of it is how can we come together, collaborate, and help work together. So out of this, we've subsequently developed some regional working groups, kind of mimicking what SIOP does, to help kind of connect people within these regions. And this picture here is actually from our meeting from back in April, where we assigned leadership of these regional working groups and talked about next steps and development of a lecture series. And so if there's folks on in the meeting that are interested in learning more about ASPHO or would like to join, there's a QR code there that'll link you to the ASPHO website. You can also go to aspho.org to learn more about ASPHO. So next to talk about SIOP North America, I'll let Cesar talk.
Thank you, Ben, and thank you to the organizer from both ASPHO and SIOP. I think that they have been doing a terrific job trying to coordinate all these things for us and for you guys. In terms of the SIOP North America, we are part of as a continental branch of SIOP. Yeah, for your information, SIOP has more than 3,000 members. All of them distribute around the world. They have been organization based on networks, committees, as well as continental branches. And as I mentioned to you, we are the North American continental branch of SIOP. They have been from SIOP tremendous amount of work through the time in low middle income countries that have been originate tremendous amount of job and development and improvement in many areas, not only for pediatric oncology, but also for many other things. In terms of the SIOP North America, we are trying to facilitate a strategic partnership between SIOP and other North American cancer-focused organizations. I think that this is very important to the overall mission that we have. We contribute to the work of SIOP's committees and networks. As a matter of fact, in SIOP Global Health, in the partnership committee, we are connecting with the different academies and association for different countries to participate and to share their knowledge and their expertise. We collaborate with other SIOP Continental branch. In particularly, we had a very important connection with SIOP Latin America. And we collaborate and we advocate to reduce or to limit disparities in care for children and adolescents in North America. Our session or our advocacy, education, global health, membership, nursing, scientific, and just SIOP. And I think that you can see in the QR code, you can visit SIOP and you can get a little more information. This interaction with ASPHO has been working out for many years because in many occasions we have to get in and in occasions we'll to try to get a little more of these international connections on place. With that said, thank you again to the organizers and thank you for Carlos to participate. I'll let to continue with Ben.
Thank you, Cesar. Yeah, so feel free to check out the websites of both SIOP and ASPHO. And if you're interested in learning more, feel free to email us or reach out. I think they're both wonderful organizations that are doing a lot of good. And so I definitely think everyone should check out these two. And so as kind of we were talking about is that we have these two organizations that have been kind of working in parallel. What we found when we looked at membership between these two organizations, there wasn't a lot of overlap between people that were in both ASPHO and SIOP. And we were working on trying to build our global health working groups within ASPHO, and felt like we really needed to be collaborating with these two institutions. And so that's where this was really coming out of, is how can we stop working in parallel and really start working together and get more people involved in global health, because that's really what this is all about, getting more people to participate. And so this was really this is the first step. So in developing this quarterly webinar series with a focus on addressing issues impacting the diagnosis and treatment of children with cancer around the world. And so this is quarterly. So our next webinar is going to be planned for November. We're still working on that specific date. That'll be given by Dr. Guillermo Chantada with a topic of standards of pediatric oncology units in various settings. We also really want to hear from you all. We want to know what works, what doesn't work. We also want to hear about what you want to hear about. What are the topics you want to hear? Are there speakers that you're interested in presenting? And so after this, you will receive a survey. I know it's another survey, but this is really going to help us make this webinar series better. So please fill it out. And after you fill it out, you will receive a certificate of attendance. Also to note, this meeting will be recorded, and we will publish these on SIOP and ASPHO websites, as well as their YouTube channels. So if you know someone that was interested in joining but couldn't because they were seeing patients or had some other obligations, please link them to these sites so that they can watch these recordings. So. And then I just wanted to go over a few housekeeping notes before we get into this. So we're going to use primarily the chat and the Q&A for questions. And so we're asking for all participants to be muted during the session. And so feel free, as this session is going along, if you have questions that come up, go ahead and enter those in the chat, and we'll be monitoring those. Also, if you have some technical issues, you can go ahead and enter that into the chat as well, and just message that directly to the host. Obviously, for best viewing experience, this is going to be best on a computer or tablet and with a stable internet connection. And then another important, which I'm sure everyone will, is to stay respectful and also stay relevant to the topic that's being presented today. And just as a reminder, it will be recorded. So with that, thank you all for joining. We're super excited about this first talk, and I'm going to hand over to Jeremy to introduce our speaker for today. Thank you.
Thank you, Ben, and thank you everyone for joining today. I have the pleasure of introducing our speaker. Dr. Carlos Rodriguez-Galindo serves as Director of St. Jude Global, Chair of the Department of Global Pediatric Medicine, and Executive Vice President of St. Jude Children's Research Hospital. He is also the co-director of the St. Jude WHO Collaborating Center for Childhood Cancer. Dr. Rodriguez-Galindo is leading an effort by St. Jude to ensure childhood cancer patients have access to quality care no matter where they live. The St. Jude Global Program has established partnerships with more than 400 hospitals in close to 90 countries, which form the St. Jude Global Alliance. In partnership with the WHO, Dr. Rodriguez-Galindo has led the development and launch of the Global Initiative for Childhood Cancer and the Global Platform for Access to Childhood Cancer Medicines. In addition to this work in global health, Dr. Rodriguez-Galindo's areas of clinical research and expertise include retinoblastoma, sarcomas, rare cancers, histiocytic disorders. He has been the chair of the Rare Tumors Committee of the Children's Oncology Group and the president of the Histiocyte Society, and has been the principal investigator of several institutional, national, and international trials. So, Carlos, over to you.
Well, thank you so much, Jeremy. Thank you so much, Cesar and Ben, for inviting me to be part of this seminar series. I really admire all the work that these two organizations are doing, and I hope that over the next maybe 35 minutes, 40 minutes, I can share with you one of these initiatives that we're trying to launch to address gaps in access to quality medications, essential medicines globally. So if you don't mind, I will share my slides. I hope that you can see them and there are no issues here. And so I want to please first start by recognizing that what I am presenting today is the work of many organizations at St. Jude, WHO, UNICEF, the Pan American Health Organization. This has been fed as well by the advice of many providers, by the advice of SIOP, CCI, so many other organizations that are trying to think together about how to address this big gap. So if you allow me, since I am at St. Jude, if you don't mind, I can start with this slide. So that was that basically takes us back to 1972, 10 years after St. Jude opened its doors. The total team, and you see here the total team, and Don Pinkel, the second on the right, the first director of St. Jude, published the kind of a remarkable paper, probably the first of many that then St. Jude was able to generate, showing that in total 5, by 10 years after opening the doors of St. Jude, actually up to 50% of children with acute lymphoblastic leukemia could be cured. And so, and in that paper, published in 1972, Pinkel and the total team said the high frequency of lengthy continuous complete remissions achieved with total therapy would indicate that ALL in children can no longer be considered an incurable disease. Palliation is no longer an acceptable approach to its initial treatment. And we have seen remarkable improvement since then. So over the last 50 years, a continuous improvement in both access to care and outcomes. And you are very familiar with this paper from COG, published a few months ago, that basically revolutionized, if you wish, our approach to the treatment of acute lymphoblastic leukemia, thinking that yes, the future is around the corner. That promise that ALL is curable is at our fingertips. And so in some groups of patients, we can think that 100% of them actually can be cured when you can bring blinatumomab, chemotherapy, and supportive care. But so how we move the needle in these 50 years? And I would say not so much. In 1972, when St. Jude reported that 50% of children with acute lymphoblastic leukemia could be cured, by some estimates, if we think about what was the global burden of childhood diseases at that time and the competing risks of death, we calculated that the global childhood cancer survival was probably around 10%. Now could be close to 100% for children with acute lymphoblastic leukemia, but unfortunately, the estimated childhood cancer 5-year survival globally is about 21%. So have we moved the needle? Probably not too much. I think it's an issue about childhood cancer is a perfect story about an inequitable disease. So we know that cure rates for childhood cancer, I'm preaching the choir here, are well above 80% with modern therapies. However, close to 400,000 children develop cancer worldwide. Most of these children live in countries with limited resources. Less than 25% of them survive. So that the global cure rates actually haven't moved much higher over the last 5 decades. And these avoidable deaths result from lack of diagnosis, misdiagnosis or delayed diagnosis, obstacles to accessing care, abandonment of treatment, death from toxicity, relapse, you know it. And yet we know that sustainable and cost-effective models are positive. So we said that the future is around the corner, but this actually, it's a local truth. It's our truth, because as we all know, there is a global truth that we all recognize and we need to act upon. That if we want to cure childhood cancer as a concept and catastrophic diseases of childhood, we need to cure the children that suffer cancer. It's not enough to advance therapies to realize that we can cure ALL unless we make it to all the children that have ALL. And addressing these challenges, what this community is trying to do, what St. Jude Global, what ASPHO, with SIOP, the Global Initiative for Childhood Cancer, and the Global Platform for Access to Childhood Cancer Medicines are about. And this is the community that hopefully can address that. And so with that, I will move quickly to the Global Initiative for Childhood Cancer that Jeremy introduced. And so that was the first time I would say that the community, as a pediatric oncologist, as a stakeholders, our parents organizations, our governments, academic institutions, really move forward to prioritize, to create that global movement to address childhood cancer from a global health perspective. And so the WHO and Jude, SIOP, and many other partners around the world launched the Global Initiative for Childhood Cancer in 2018, already 7 years ago, with that goal that by 2030, we could probably dream of curing 60% of children with cancer and alleviating suffering for all, overall saving at least 1 million additional lives over this decade. And as you know, you are very familiar with the Global Initiative for Childhood Cancer, works with governments on the implementation of a technical package that is called Cure All. And Cure All has multiple work streams, if you wish, but there are some core projects that address each one of the components of the Cure All package. So addressing cancer health systems, national cancer control strategies, implementing cancer workforce training packages, national networks and referral pathways, defining national standards and guidelines for index cancers, essential medicines that I will bring up in a second, economic analysis, cancer registries, dashboards, and advocacy portfolios. But then as GICC started advancing through this engagement with governments, it was clear that on the 70 plus or close to 80 countries and governments that are engaged in the Global Initiative for Childhood Cancer, 80% of them, if not more, requested action on improving access to childhood cancer medicines. This is a problem that we recognize here as well through shortages and interruptions in access. But when we see a tremor here, a threat of having a shortage of one medication, think that worldwide this is a tsunami, so that institutions then will actually go without some cancer medications for months, and that is usually replaced by counterfeit medications. So this is where we started. So how are we going to address this problem, and should we start proposing a solution? And so this is a broken market, as we know, that leads to broken lives, broken families. So what are the problems? One is availability, we all know, of essential cancer medicines around the globe. This is inconsistent due to supply chain and demand issues and complicated regulators, to the point that about only 29% of low and middle income countries report that cancer medicines are generally available. Second problem is with accessibility at the point of care where the patients receive care, because of limited network of facilities that could provide medicines, resulting in treatment delays and abandonment. And in some surveys that we did, about 43% of partners around the world report suboptimal access to childhood cancer medicines at the point of care. Second or third is affordability, the cost. Even though you would think that the cost should be low, the cost of childhood cancer medicines is often excluded from budgets, creating this financial hardship for families. And then the market, as a broken market, is very difficult to regulate, to the point that actually with the low volumes, poor supply planning increases the cost. As you see here, some centers and for some drugs in India and China or South Africa with a poor access to medications actually pay much higher prices than what we pay in North America or in high income countries. And finally, quality. I think that we all are very much aware that in this process of broken systems, the quality of medicines is threatened when there are low quality products that fill in that vacuum. There are several studies that have shown that. I share here a couple of studies. One is that cancer drugs are the most common products among the non-communicable disease medications that show poor quality. There was a paper recently published in Lancet Global Health that many of you have seen, that basically scanning or testing medications currently being used in sub-Saharan African countries, so that up to 25% of the medications that were currently being administered in those countries were of suboptimal quality. That is something that we know, but we don't know exactly how to address. So what did we set out to do to try to conceptualize these, try to define the problem, try to develop a solution? So WHO and St. Jude in 2021, in collaboration with UNICEF and the Pan-American Health Organization, set up a working group to trying to optimize a potential pool procurement similar to the Global Fund of sorts, We initially were able to secure some initial funding of $200 million committed over the next 5 years from St. Jude, while we develop a more sustainable, financially sustainable platform with a goal to providing medicines to approximately 120,000 children in 50 low-middle income countries by the end of this 5-year period. So what we wanted to achieve was to increase the percentage of children who would complete treatment, ensuring access to safe, effective, and quality assured and affordable medications. What should we do to get to that goal? We need to actually, we'll talk a little bit more about this, shape markets for childhood cancer medicines, provide cancer medicines to children at the global level and at the national level. And what needs to be done for that? Hopefully develop this global platform that I will share with you with proper management. But then, as important as developing that is just strengthening the process at the country level to make sure that the products that we could provide are safely distributed and equitably distributed. So how does the global platform would like to work? First, by only relying in manufacturers that have SRA, stringent regulatory authority approval, say FDA, EMEA, and others, that would assure the quality of the medications. By effective pricing approaches, by pool procurement, would be able to reduce out-of-pocket costs, financial toxicity, making more affordable. By providing good, accurate quantification, forecasting, engaging with governments, and with a good system that would provide a rapid response, would make it available. And then by engaging at a country level, as I will share, the community, the pediatric oncologists, the parents' organizations would make sure that this is accessible at the point of care. And then most importantly, this has to be owned by the countries, has to be defined by country ownership so that we can create a process that is not charitable, that is actually a strength, health systems are strengthening. So the global platform has a governance structure that is currently being defined and optimized, but has a steering committee that is formed by St. Jude, WHO, and the partner organizations like UNICEF and Pan American Health Organization, but has an administrative and operations unit, let's call it a secretariat, that is based at the WHO. So this is a WHO program with working groups, technical teams, and then the procurement agents. The procurement agents, the institutions that actually will engage with the pharmaceutical companies, with the manufacturers, buying and distributing, our UNICEF Supply Division and the Pan American Health Organization, a strategic fund for the Americas. And then this process is in constant engagement with the countries that enter this process, with the suppliers engaging directly across the board. And then the next step, as we have been discussing, is now we bring partners to the table, different organizations, to provide advice, support, and technical recommendations, which is the next step. And so what is important, as I said earlier, is that this is not a charitable donation program. It's a health systems a strengthening tool, almost like a lever. And one of the elements that is required for that is a proper country governance. And so there is engagement from the ministries of health, the civil society, parents organizations, advocacy groups, the national regulatory authorities. Has to be a central warehouse mechanism. And then the hospitals and the health workforce have a say in this, in the governance of the process. So they are not in the receiving end, but they are in the governance. So that country governance is critical to assess and monitor the demand for medicines, to monitor the facilities that will be participating, developing an operational plan, overseeing the receipt, the distribution, the use of medicines, accountability, communications, and coordination with the global partners. And so over the next 5 years, and we're already on year 2 of that, we decided to create a 3-step process with a development phase, a pilot phase, and a growth phase. The development phase is basically creating this business model that I described, creating that collaborative framework between the partners, setting up the operations unit, that secretariat at the WHO that will be overseeing and managing that, and then engaging then in the process for country eligibility, etc. It's just basically creating the business structure for that. We are now in the pilot phase, which is engaging with 12 countries over 2 years, 6 countries and 6 countries, representing the different WHO regions and representing different settings. Based on size, in number of centers, in number of regulatory complexity. So we have a portfolio of multiple examples. And so then during this pilot phase, we co-design with the partners. We do a in-country governance structure, as I will share with you, looking at mechanisms, tools, resources, regulatory pathways, and that's basically the optimization of the structure. And then hopefully next year we go into the growth phase, which is basically a rolling process where countries start the process, engaging with the Global Initiative for Childhood Cancer, fulfilling some of the commitments, and then as they reach different milestones, they start receiving the medications. So these are the medicines approved for procurement. These are most of them in the essentials medicine list with 35 unique products, 58 formulations. All of them have to be approved by a stringent regulatory authority so that it's a quality control mechanism. Additional criteria to essential medicines based on the formulations was also based on what we could hear about reported frequency of stockouts or shortages or concerns of some substandard falsified products among some of the products. And so that's basically the process of selection of the specific formulations that are eligible to enter. I mentioned the last mile, that it's basically the country ownership. As we start this process, each country has to optimize the process. It's not about delivering the medications to the port of entry, it's what happens after that. And that's basically the last mile, which may be the most complicated process because each country is different. Some countries may have only 2 institutions, others may have 15, and that creates a higher level of complexity. Some countries have a very mature regulatory process, others not, and we need to make sure that everyone gets to that point. So we do an exercise of co-designing with each country that is individualized to adapt the processes with depending on what are the needs and the opportunities. And in this process, the platform engages in a collaborative readiness assessments with the governments, looking at the country-led situational analysis, global platform assessment. Then the Ministry of Health and the global platform jointly agreed upon an approach for this last mile, if you wish. We look at that, or the platform looks a lot at the supply chain capacity assessment, focused on minimum standards, on port logistics, central warehousing and distribution. As you can imagine, temperature and humidity management, inventory control and dispensing, replenishment and reporting. And at the same time, medical teams do a clinical capacity assessment focused on minimum standards, personal training, chemotherapy prescribing, safe delivery of chemotherapy, incident management, and make sure that before the countries start receiving the medications, these minimum standards have been reached. There is then training, there is support for pharmacies, for pediatric oncologists, for regulatory authorities, and there is funding as well for some of these early packages to be completed. And so this is not a donation program, as I said. So by doing that, what the platform means to do as well is to reinforce the political commitment for childhood cancer control and support governments to safeguard families of children living with cancer. So there is a good commitment for that. And it provides support for governance, for procurement planning, for clinical and supply chain assessments, technical and financial support, and a very robust monitoring and evaluation. Then it takes innovative approaches that hopefully will address the fragmentation of childhood cancer medicines through market shaping and collaborative partnerships. So how do we work? We have these kind of 6 interdependent work themes that are being addressed in terms of governance, forecasting and quantification, clinical management, supply management, regulatory pathways, and monitoring and reporting. These 6 work themes are interdependent, as you can imagine, that are very technical and so require a lot of input for many specialists. And each work stream works concurrently with theme leads and engaging with governments. And then these specialists around the world at the country level, across different fields, just come together with logistic experts and regulatory authorities to optimize the process at the platform level as well as at the country level. And so this is how more or less in a high, view how the operations evolve. And so as we engage with the countries, there are basically like 3 steps, if you wish. One is the system readiness that can take up to a year, if not more, focused on assessment, priority actions. Then as they start receiving the medications is part of where we are right now with the active receipt. Usually by year 2 or year 3 in some countries, they start receiving the medications. They receive regular shipments of medications based on the forecasting and the monitoring of use. And then the next step is eventually develop a plan for sustained supply through a different process that we're working country by country that hopefully would also lead to country ownership of the financial costs of that. So participating countries are encouraged to view their engagement as a sustained partnership that evolves over time and that they have to own. And so this can be kind of blow up, if you wish, in more detail here. So I would say there are these 3 steps. One, this preparatory phase with a country operational plan. We work with the governments on orientation, what it means to be part of the platform whenever they are ready. We do assessment visits. Then usually at the same time, we start working on the procurement planning. And so they will have proper forecasting. And then we start the implementing phase. So usually once a year, as new cohorts of countries come on board, we do then the global platform forum, as we call it. So there is a joint onboarding, if you wish, and then share experiences with the past members. And then we start with the technical support country visits, additional procurement planning window that then opens, and that takes about a year in this whole process. And during this process, the countries are assessed against these minimum standards, and we help advance through these minimum standards to the point that they are ready at the regulatory and at the clinical level. So it's a health systems strengthening tool. And so the platform then continues to improve its governance, policies, processes, and templates to facilitate this management. We'll not have time to go over that, but you can imagine there is a lot of monitoring. On the top right corner, that Power BI is basically what we call the control tower at WHO that basically monitors the process from the procurement order all the way to the country. And then we work, or WHO works with the DHS2, which is a database managing system to then do proper monitoring of the individual use of the medications for proper use, for accountability, etc. So a lot of data that goes into that, and then a lot of data that goes into the assessment with the institutions, the training for pharmacists and pediatric oncologists, that it's all collected with different opportunities for engagement. So this is basically where we are right now. We have completed the first cohort of countries that you see here, representing each one of the 6 WHO regions: Ecuador in the Pan American Health Organization, or the WHO of the Americas, Zambia for ASPHO, Jordan for the Eastern Mediterranean region, Uzbekistan for the Euro region, Nepal for the Southeast Asia region, and Mongolia for the Western Pacific, the West Pacific regional region. And then the second cohort that was announced recently are these countries: El Salvador in the Americas, 2 countries in Africa, Senegal and Ghana, Moldova in Euro, Pakistan, and Sri Lanka in the Eastern Mediterranean and the Southeast Asia. So this is basically the 12 countries that have been part of this pilot phase as we conclude the pilot phase with the first 6 countries already in the process of receiving medications, except for Jordan, that is a little delayed because of regulatory issues, but the other 6 countries hopefully ready to receive the medications by the end of this year. Here I have a few pictures of some of these countries receiving these medications in February. So actually it was the first week in February where most of these countries in Zambia, in Nepal, started receiving these medications. So what impacts are we seeing at the country level beyond the delivery of medications? First, obviously, the delivery of medications that's a proof of concept, so that this year, in 2025, within the 2.4 million medicines will reach 6 countries, reaching 6,000 children in 30 hospitals. And then by the fall, hopefully the 6 or the beginning of the winter, the 6 new countries will start receiving their medications. And so this, as you probably can imagine, has led to a massive effort in strengthening the supply chain, the regulatory processes, the clinical practices for the countries to be eligible, for the governments to be part of that in developing that country governance. Then we have seen a few examples of how this could be seen as a lever just for the health systems to be strengthened across the board. For example, Nepal, as being part of that, felt that the government thought, okay, so we are part of GICC. There is a global effort to provide medication to our children, so let's provide an added value to that by creating a financial package for children with cancer, so that medications will be provided by the platform, but everything else will be provided by our financial mechanism. So suddenly, in 1 year, we go from a completely unregulated system in Nepal to a very strong health system where there is universal health coverage for all children with cancer. And then Ecuador, for example, led by the National Pediatric Oncology Community in this country governance structure, together with the Ministry of Health and the Global Platform, approved the inclusion of 3 new formulations to their essential medicines list. So you see progress at many different levels, and we see that all over and over in most of the countries. Then the other thing I would like to share with you is that the first tender for these first 6 countries was the largest tender in global childhood oncology that was ever done through UNICEF and the Pan American Health Organization, with 58 formulations based on the essential medicine list that all had to be approved by stringent regulatory authorities. That has led to more than 14 long-term agreements with companies that will commit moving forward, with pool procurement as an enabler to set very competitive prices that we think, as we increase the volumes, these negotiations would actually be even more meaningful. And then there has been an engagement with GAPEV, which is this organization within the WHO, to optimize formulation for pediatric medicines, to engage as well with us and with companies to optimize formulations for some oncology products. And so GAPEV now has brought the platform as well to the mainstream for that particular purpose. So there are several communities that are being built where governments, providers, stakeholders can be part of, because, as I said, it's critical that this has a country ownership, a community ownership, rather than a top-down approach. So you can hear more, you can see more in the St. Jude Global Alliance online community, but WHO has set up as well a page with a lot of information in the Childhood Cancer Community of Practice in the Knowledge Action portal. So for this end of this year and next year, we hope to accelerate the readiness of the second cohort of countries for deliveries of medications and see how we can continue the supply for the first cohort, strengthen the monitoring and independent evaluation. So make sure that this platform accomplishes what it's set up to accomplish. We're going to start a market shaping strategy and initiate some implementation of some interventions in working with pharmaceutical companies, and then initiate a scale up to other countries, hopefully, as the pilot phase concludes. Just thinking about future sustainability, I want to let you know here that, yes, we had this initial commitment of $200 million. As you can imagine, that's not enough to scale up. The idea was as a proof of concept while we start working on financial systems with a multi-donor trust, engagement with governments. Governments might be able to purchase from the platform, so that will provide still a low-cost solution for medications that are of quality, right? So with quality assurance. And so that's how the platform hopefully will work, and then eventually start incorporating some of the medications that might not be in the essential that may become in the essential medicines list in the future, and then intensify more partnerships with communities like all of us to try to continue to think about what are the next steps. Engaging with stakeholders, communications, and the governments of the platform will grow to start incorporating these stakeholders and these partners. And so this is basically where we are at this moment. So we think that this is, I hope that you can see it as well as a transformational moment. This is a unique opportunity to build on the global initiative for childhood cancer, ensuring medicines are delivered in systems and facilities that can provide comprehensive quality of care for children with cancer. As I said, this is not just a donation program, it's a community-based effort that brings in partnership the countries, the owners, the communities of practice to solve these persistent challenges to childhood cancer medicines access through a very holistic approach that would address the end-to-end challenges. So key to this is, again, collaborating with the national stakeholders to understand each country's unique challenges, to identify and address barriers to handling and storage of chemotherapy, and apply these system-based solutions to strengthen the supply chain. And then finally, one added value to that has been that connection of countries across the spectrum to exchange knowledge and share experiences to create a little bit more like a synergistic change and a learning process that we, as new countries come on board, can benefit from what others have done to resolve some of these challenges. And so I think we all agree that these are these opportunities that sometimes only happen in the pediatric oncology community with organizations, ASPHO, SIOP, WHO, St. Jude, the GICC, etc., that we start these global movements, and I think that togetherness is critical to change history. I want to thank, I started by saying that this is something I am presenting, but this is a work of many organizations behind the scenes. I show here pretty outdated picture of some of the partners from all these 4 organizations that are part of that. Now we have a fully constituted secretariat at the WHO. I want to introduce you to the new lead, the technical lead that will be representing the global platform together with his team at WHO. That's Santiago Millan, that hopefully in the future our community can get to meet, because you will be hearing more from him. He just started a couple of months ago. And with that, I will stop. I thank you all for your time. I don't know if we have time for some questions as well.
Thank you, Carlos. That was a wonderful talk. It's incredible to see what's happening right now, and it seems like we're at a pivot point. And I think the pilot study is really exciting, and the next steps are going to be incredible to see what happens. It also seems like a ton of work. So working with all these different governments and organizations, it just seems like a real challenge. So congrats on everything you've been able to accomplish. We do have some time for some questions, so we've got a few in the Q&A. So other folks on the call, feel free to add them to the Q&A. So to start off, we got some questions from Francis Eschen. So they mentioned that the goal is to strengthen the country's healthcare system, not simply to provide donations. So the question is, does this mean that countries are expected to repay the support they receive?
Yeah, no, thank you so much, Francis. No. This is not a financial expectation at all. So I think what we hope is that the countries repay internally by strengthening the systems, like we saw with Nepal, providing added value by creating a universal health coverage, by improving number of providers, etc. So this is not a financial transaction at all.
Yeah. And Francis also had a follow-up question about, do you include private hospitals in these countries during your assessment phase?
Yeah. So yes, there are in many of these these countries, part of the pediatric oncology services are provided by private institutions. I think the point has to be that this is under a universal health coverage, so there has to be no cost for the families. And if the governments have engagement with private institutions, as long as this is part of a national cancer control plan, this is supportive. Remember, the countries have to develop their own solution to that and their own implementation plan, and that's the only requirement.
Gotcha. And then another question was, how do you ensure that the medication provided is not resold for profit and that is actually getting delivered to the patient?
Yeah, absolutely. Yes. Recently, we had a scare because you may have read that in Zambia, some of the medications for HIV, TB were resold, etc. So yes, we have a whole system for monitoring and evaluation, track and tracing at almost, I wouldn't say at the vial level, but at the shipment level. And so that the HSI2 process that was set up in Norway by an academic program that it's used for several programs at WHO level to track and trace. Yes, so that's critical. That's absolutely critical, and we need to monitor that very closely, and definitely this is something that the countries are very much aware that they need to monitor. Yeah, but it's a risk. It's a risk always.
Yeah, no, I'm certain. All right, we got lots of questions coming in. So another question, this is from Andres Diaz. So happy to see what looks like a med student on here from the University of Arizona. So Andres says, thank you for this insightful talk. Honored to attend as a student. Question, one of the long-standing challenges in pediatric oncology in low and middle income countries has been limited participation in clinical trials due to fragmented access to medicines and treatment infrastructure. How does the global platform for access to childhood cancer medicines align with ongoing or future efforts to support country or region level pediatric cancer clinical trials?
Yeah. A very good question, Andres. I think we have to be very careful that this is not a research endeavor. Yeah, it's research from the point of view that is an implementation research, but it's not. It's just unlinked from any efforts at using these medications for clinical research. There could be clinical trials that will grow around that as we strengthen the systems, bring the community together. There could be opportunities. But this platform is not set up to facilitate access to research medications, that's for sure. But as you very well know, in the pediatric oncology community, whatever we do has to be with the research framework, and we try to encourage that eventually, some of the interventions have to have research methodology. But yeah, this is not set up to link the interventions to clinical trials.
Yeah. Then we have another question from Mogobotsi. So they ask, when do you anticipate cohort 3 to be announced?
Yeah, so the first two cohorts were announced, the countries were designated, they had to apply because it was the pilot phase was set to develop the model, it's just the prototyping. And so we had to make sure that we selected a limited number of institutions. Once the pilot is done, there is no cohort anymore. And so then basically as countries and governments engage meaningfully in addressing childhood cancer control plans, we have several criteria that have been set up. They have to be part of the Global Initiative for Childhood Cancer. So there is a commitment to strengthen system, be part of national cancer control planning, etc. So there are several requirements. And then as they engage, the government need to ask to be part of that. There is a process of application, if you wish, and then means that because then the governments have to be committed to fulfilling some expectations at the regulatory level, at the systems level, at the institutional level. There is a lot of processes for that. Drug registration, waiver for registration. There is a lot that the governments need to commit if they want to be part of that. And then hopefully as they engage in this process, then it's a milestone-based approach. A government starts processing, engaging, there are inspections, there are discussions, and then by that moment they start receiving the medications. It will be more like a roll-in process based on eagerness, engagement at the council level. Yeah.
And then Benjamin has a good question here that I was also kind of thinking about is, what are the biggest challenges you encountered during this pilot phase?
Well, I would say that the biggest challenge has been probably more at the operational level, setting up the whole business model for that. And then as we engage with countries, we realize that, there is not one pattern that fits all. Each country is different. The problems at the country level are oftentimes unpredictable until we start the process. So I think that the challenges have been more try to go from what we thought was going to be maybe a more uniform approach to having to realize that there has to be a very one-on-one coaching at a country level, which increases the engagement of the partners involved. So I think it's just the complexity of it. But we have worked a lot on lessons learned from pilot 1. Now lessons learned on pilot 2. We tried to optimize it. If for the first pilot, it took almost 18 months for the countries to receive medications. For pilot 2, I think it may just be less than a year, so maybe 8 or 9 months. So I think we are improving that, yes.
Yeah, that's great. And so I think we have time for maybe 1 or 2 more questions. It looks like we're approaching the end. So Ronald Barr asks, how are the published problems of WHO oversight of falsified and substandard medications resolved?
Yeah, Ronnie, thank you for this question. I was hoping you would not ask it, but but you're absolutely right, Ronnie. It's a problem that the WHO is trying to address. So I think that there has been a lot of concern about all these news coming about the falsified and substandard medication. So it's a process, and so I think the global platform gives us a unique opportunity to really tighten this process about quality control. And so it's has been very difficult, I would say, to oversee this market based on my engagement. So, but we're just taking this very seriously. Yeah.
Yeah. And then we got time for 1 more, I think. So Cesar, I see your hand raised. Maybe go to you.
Yes, thank you, Ben. Thank you, Carlos, and all the institutions of St. Jude. This is terrific approach, and this is incredible the amount of work, logistic, operationally, and definitely at the end of these elements. But one of the questions that was raised, and I would like to emphasize, is about the clinical trials. And I think that there are different steps in every process, as Carlos had mentioned, that require implementation and optimization. And definitely, clinical trials is going to be important, but perhaps it's a little at this moment, as Carlos mentioned, is not in the main scope. Also, I know that St. Jude is working in that as well. But this is one of the scenarios where participants can join SIOP and ASPHO and collaborate with these entities, because at the end of the day, everything is going to be with a common goal. We need to improve the survival of the pediatric population affected by cancer. So I think that we have inside of North America delineated a way to do it, and I know that they have the same in ASPHO. So I think that the participants can consider some contribution in that, and I think that it's going to be terrific, because at the end of the day, it's going to be improving the overall land to produce results in different aspects. So
Yeah, thank you so much, Cesar. This is excellent points. I think that we're at the beginning of this process. There will be so many things that could be added to optimize the platform, the engagement by the different communities. I think that is this is the beginning of the process. I see that there are so many questions coming. I just looked at the chat. Unfortunately, we will not have time, but happy to respond to them in writing, or if anyone wants to reach out to me, I can share the emails of other members of the platform that could be more appropriate to answer one or all the questions. So happy to engage and put together a little bit more information about what the process is and how it works. Okay.
All right, I think that'll wrap it up for today. Thank you so much for that talk, Carlos. I think that was excellent. That's a perfect first webinar series. I think it went really well. We had great engagement from the community. As you mentioned, like, you have a lot of questions out there, which just shows how important this topic is. So thank you so much. And thank you to all of you for joining. Please remember that there will be a survey sent out. Fill that out. We want your ideas of how to make this better, ideas for talks, ideas for speakers. So please fill that out. And then you'll be hearing from us about the November webinar. Hopefully soon we'll solidify that date and get those emails out to all of you. So thank you so much.
Thanks so much, all of you, and happy
thank
to
you, Ben,
follow up
Carlos.
with any additional. Thank you. Okay, bye-bye.
Bye.
Thank you,
Bye.
Carlos. Thank you, Ben. Thank you, Susana, Jeremy, all of you guys. Take care.
Thank you, everyone. Thank you.
Bye.
All right.